they notice this vision?
قلنا almost couple of years now she start they've noticed this back deformity and start progressing over the couple of years. عشان الانتربشن اللي بيصير ما هو مثل ما بنتقابل face to face في المستشفى. ف when I ask you a history, I want you to give me all the points you got in history عشان نزيل الانتربشن اللي بيحصل في الكوميونيكيشن هذا. ف I want you to take your time, ask all the questions that you think is relevant to the scenario I gave you and the X-ray you have in front of you. And when you're done with additional comments about your questions, whether is it complete or anything additional to be added.
Okay.
Did you hear me?
Yes.
هل صوتي واضح يا شباب على فكرة؟
واضح
أيوة.
واضح يا دكتور مقبول.
واضح. So
توكل على الله.
Yeah, so the main complaint here is the deformity.
أنا ماني سامعك إذا أنت بتتكلم. هل بيتكلم ولا ماني سامعه؟ أحد سامعني؟
لا
لسه ما بدأ.
أحمد سامعني؟
ايوه سامعك دكتور.
So regarding the presenting complaint, I will ask more about the history. So it started a couple of years ago. I will ask about any associated symptoms.
المعذرة حبيبي، أنا شكله عندي قطع وشبك ثاني فما سمعت منك ولا شيء من آخر مرة سمعت صوت.
طيب.
Can you repeat again please? What sort of history you want to ask?
طيب حسأل عن other complaints that are related to this scoliosis. So I will ask about any chest complaints, any back pain, any neurological deficits, like lower limb pain or gait problems, bowel bladder control.
Jamil, anything else?
Like numbness, also the pubertal signs of the kid, and
بتتكلم على بنت عمرها 10 سنوات.
10 سنين. So menarche, did she start menarche or not yet? Other than that, I will go to past medical and surgical history, and I think that's the main questions I have.
Very good points. So this kid is complaining mainly of her back deformity that was progressive over the past 2 years, and it was noticed by the physician from the pediatric who noticed that, and the parents also reported the same things, but they were not really paying much attention due to the chest problem she got. And in addition to the deformity, she has mild back discomfort, not interfering with her daily activity, but not a real back pain. And additional answers to your questions, she is not yet gone through menarche, and she does have medical problems, which is a repeated chest infection, and she has multiple hospitalization to the hospital, multiple admission to the hospital with the repeated chest infection for the past 4 to 5 years, and that frequency increased over a time, and she was just discharged before referring to our clinic from the hospital following a recent chest infection, and she was admitted and treated with antibiotic course for almost 2 weeks, and then improved, discharged, got the follow-up to our clinic. You ask about any weakness, loss of sensation, and she doesn't have any of these. Bowel and bladder function, as you've asked, is intact, not involved, full control. Any additional question that you asked I didn't answer?
لا.
طيب. Anybody would like to add any additional questions on top of this? Open for the second junior.
براء أو أي أحد من الآخرين.
دكتور
additional questions فوق اللي قالهم. He addressed multiple points, very important, valid points. But anything else you want to ask additional to his questions?
Has she been diagnosed with a genetic disease?
Good point. No, it was not diagnosed with any genetic disease. How is that relevant?
The association of genetic disease, like in patient with neurofibromatosis or patient with it's called Scheuermann's disease.
Those two are separate. But if I tell you that this patient has a syndromatic kit, would that be relevant to anything in your mind?
Like the Vactrel syndrome?
Yes. So if I tell you that she was diagnosed with Vactrel, what would come across your mind as a cause of patient presentation?
She would have abnormalities in her spine formation or vertebra formation. So she's having possibility of hemivertebra or fused vertebra or spina bifida.
Okay, so what would you call this group? What sort of scoliosis is this? لو كان عندهم Vactrel and deformity, what sort of scoliosis you're talking about?
Infantile?
No. You just described the feature of the abnormalities of the spine column and the vertebrae. Hemivertebrae or failure of formation, failure of segmentation. What do you call this group?
Congenital.
Congenital, yes. So that's a congenital scoliosis. By just asking your question, you get the diagnosis. So this case doesn't have any diagnosed syndrome. Any additional questions you want to ask?
Nothing in my mind.
Okay, now, seniors, any additional questions we did not address so far?
Yeah, I would like to ask about the chest problem she had before. What exactly?
Okay, so she get an upper respiratory tract infection and then progressed to lower chest problem, and she get a chest pain and cough, productive of sputum, and she get hospitalized for treatment of pneumonia, and that became more and more over a time in terms of frequency.
Okay. Also about any other medication she's taking, a past medical, and also did she had any bracing or other treatment for her spine?
For the spine, it was the first time she got referred to any service of this kind. So she is the new patient referred to you for the first time. And she is not taking any medication. Apart from the medical treatment that she's taking, whenever she gets a chest problem, she uses inhalers, and that is being given to her to support her recurrent attacks. So that's the only medication she was given by the pediatric pulmonologist.
Okay. Also, I would like to ask about the perinatal history to rule out if she had previously CP undiagnosed or no.
No perinatal, any important finding to be reported. So
Okay.
she was normal kid, prenatal, postnatal, all negative history for any active finding, and she's been raised as a healthy kid.
Okay.
You're quite satisfied with the history so far, everybody? Nobody has any questions additional?
Family history.
Family history. Yes, she has a family history of a similar problem. Her auntie, she got a similar problem and was operated for a back surgery for correction of a deformity. Good point. Any additional questions?
I think no more questions.
Great. Like, I would ask additional questions about her ability of functional ability, what things she could do and what things she could not, in order to understand her limitation if she has any physical limitations. For this girl, no, apart from outside activity, she lives in a village, and that is out of Taif, And whenever they have a sandstorm, she gets a problem, and she gets like an attack of shortness of breath, and she needs to use the inhalers much frequently. And apart from that, physically, she's fine. Like, examination. How would you examine this patient, Bara?
So we would start with the general examination by assessing the patient's gait. If
So
she
she
has
walks.
any...
She walks normally. She is underweight, but she walks. Her gait is maintained without any significant deficits.
Then general inspection of the patient, looking for any abnormality or syndromatic facial characteristics. Then specifically to inspect the spine, do the Adam forward bending test, look for difference in shoulder height, look for pelvic tilt, or also inspect over the patient's back for any hair tufts or discolorations that would indicate spina bifida or any underlying abnormality.
Great. So you look for any possible skin changes like hair, discoloration. What sort of discoloration?
Cafe au lait spot.
Good. Additional? Anything else?
Any skin indentation that would indicate rotational deformity of the rib cage.
Yeah, good. And skin changes itself. Additionally, you might look at, let's say this patient has a dimple in the back at the mid-thoracic. What would that possibly indicate?
Underlying syringomelia or
Yeah. So syrinx is just a finding that is related to another problem. So that will indicate a possible neural tube defect.
yes,
that might be there. And if you see it at that level, especially higher up than the lumbosacral, a common problems will be what sort of disease that can give you findings similar to that. Dimple in the thoracolumbar spine with a tuft of hair, I would say.
Yeah. Spina bifida.
Okay, so it's a neural tube defects can vary according to the severity. It can go even more extensive to a failed all lining of the dura to reach to complete myelomeningocele, where you have a completely failed coverage for the dura. So that's also something to look at. What else you want to look at when you examine the patient? So you said the rib hump, and you looked at the waist asymmetry, the pelvic tilt, limb length discrepancy you've mentioned.
no, I didn't mention. I mentioned also the shoulder difference in shoulder height.
Good. Shoulder height is also important. And as well as trunk. You want to see the trunk, is it centered over the pelvis when she walks, or you can
shifted.
see some shifting. It can be picked up at the time of the examination. So classically, when you examine these patients, what would you like them to be dressed?
I would like to expose the patient trunk and examine from the back.
Yep. So you want them to be in pant and then gown, so you can inspect things clearly. Most likely, you will be able to pick things properly if you do it that way. But if you do it with a patient that is completely covered and you just inspect things like we do in the clinic most of the time, it's improper way. So typical answer when you're being asked to examine a patient with a possibility of scoliosis, you want them to be in that situation. طيب. And then you want to assess the limb length discrepancy. Why?
To see if there is any tilt in the pelvis that's being compensated.
طب لو في limb length discrepancy وفي scoliosis، مين السبب؟ scoliosis سبب limb length discrepancy أو limb length discrepancy cause the scoliosis?
I would say that limb length discrepancy caused the scoliosis.
طيب وكيف حتعرف الكلام ده؟ كيف تثبته؟
By measuring the apparent and true leg length.
طيب لو لقيت بالفعل في رجل أقصر من رجل، one limb is shorter than the other، إيش حتسوي؟
See if the scoliosis is a structural or not structural by correcting the limb length discrepancy by a block.
Very good. Exactly. So you put a block and then you repeat the X-ray with the block after you compensate for the measured deficiency that you did. Very good points. طيب. Any additional point you want to do in the examination?
We would do also the Adam forward bending. I don't know if you heard me.
Yeah, you did. You did that, and you could see what sort of finding you will see when you do Adam forward bending test.
We will see the one side of the posterior thoracic cage is higher than the other, or the scapula is higher than the other.
Okay. تفرق معك في إيش هذا؟ What does it mean?
There is element of rotation.
All right. So that is exactly the amount of rotation that is associated with the component of scoliosis. Great. Right. What else?
Like we could also extend the examination to see the feet of the patient. If there is any high arch or pes cavus, it would indicate neurological issue or neuromuscular disease.
Great. Right. What else? Keep going. Going well.
شوية فرملت.
Yeah, going well. كمل. نزلت للفوت. طيب كمل ايش حتسوي عند الفوت؟
reflexes.
طيب بس ريفلكس كده. طيب ما في مجموعة كبيرة محترمة كده you should say.
This neurovascular exam.
لا neurological. خلينا نبدا الفاسكولار. complete neurological examination. قلنا دائما انه speak of spine يعني لا تنسى انه البين سبب مشكلة وجوته في nerves. So you have to pay attention to the nerves that crosses the spine. You would understand if there's anything associated with it by examining it. So you want to perform a neurological examination, both lower limb. إيش هتسوي؟
We will do motor, sensory, and reflexes, checking for tone and power.
جميل. So you will do a complete detailed neurological examinations of the lower limb. إيش الفايندينجز اللي هتكون مزعجة لك؟ If you see it, it would mean something.
If there is any increased spasticity, hyperreflexia, or any focal neurological deficit that would indicate nerve root compression or.
What would you say if I tell you that this patient has a hyperreflexia of both lower limb, ankle reflex, as well as ankle reflex, as well as knee reflexes? What would you think?
Upper motor lesions.
Okay. So that is a sign of upper motor neuron lesion associated with scoliosis. Good. And what else you would do if that was not present? You examine the lower limb and it's completely normal. Are you satisfied with that in a case of scoliosis, or something else you need to do?
Move on to sensory, you mean, or?
You did the complete neurological examination of both lower limb and it's intact. We're done? Closed? Are we done, Bara, or something else you want to do to complete your neurological examinations of a scoliosis case?
Nothing in mind, sorry.
R3 انت الآن؟
R2.
R2. Good. R3 can help.
Abdominal reflexes.
What does it mean? And how would you do it? And what does it mean?
While the patient in this supine position and the abdomen is exposed, we can scratch the abdomen from the outer 4 quadrants toward the umbilicus to see if it is symmetric or asymmetric or absent both sides.
Okay. And what does it mean?
If asymmetric, it would indicate pharyngomyelia, and this is an indication for MRI to look for any other abnormality in the spine.
Very good. So that is a sign that there is an intraspinal pathology, and if that is present, then it will draw your attention to a possibility of intraspinal pathology. So in addition to the neurological examination, this is a part of it. Very good. Like, any additional thing you want to do? Like, that's enough, I think, as a sort of examination. We've done the regular examination, and in this young lady, she had a deformity of the back that you could see. It's evident in the X-ray, and some rotation that is present mainly at the mid-thoracic spine. Apart from that, all the remaining examination that we've talked about is intact. She doesn't have any findings of the examination. Anything else we will need to examine in this kid? حاجة ما انتوا واقفين عليها طبعا.
Tanner stage.
نعم.
we identify the Tanner stage of her
Yeah,
pubertal.
you could do that. That's a good point to know her stage of maturity, and we will discuss this. You could do the Tanner staging to stage her maturity. That's a good point. Remember, who referred her to you is a pulmonologist, pediatric pulmonologist, because of her current chest problem. So you need to examine the chest. Listen to the scenario always. If we put the scenario that she has a chest problem, and I keep on talking about it, multiple points. So you have to ask about that in the examination. So when we examine her chest, she has decreased air entry, mainly on the left side, and she has some wheezes on that side as well. Apart from that, no other important finding in the examination. So now, this is her situation, and it was already, the X-ray was already requested and given to you. So what sort of X-ray would you usually ask for when you have such a patient? كملي دكتورة.
We will ask about the scoliosis series, including the PA and the lateral, as well as the bending images for the spine.
Okay. أحد له إضافة؟
While the patient is standing.
Good. Standing. And that's the important part. So you need to say standing X-ray that shows a full spine, including pelvis. Good.
Yeah.
So that's what you got here. Can you please read it if you can see?
Okay. This is a PA view of the spine, showing coronal deformity of the spine, mainly in the thoracic and the lumbar region, with the right thoracic curve and left lumbar curve. I'm not sure about the degree.
طيب هذه النقطة حيكون من الصعوبات حق الدسكشن تبعنا، لكن I will trust your eyeballing. So what would you think this curve magnitude will be? Where is the main curve?
I think it's mainly thoracic.
Okay. When you evaluate scoliosis, طبعا هذا we can spend a good time in looking at the way of measurement and then analysis of the magnitudes. But in brief, what system would you apply to make the measurement? Raiban, what classification system you would use?
The Linke classification we can use.
Good. So Linke classification, you will identify how many curves?
We have the main thoracic, and we have double thoracic, thoracolumbar.
No, that's not what I meant. When you look at any X-ray, غالبا حيكون عندك في curves معينة، مثل ما تفضلتي حيكون في عندك main thoracic وحاجة فوق المين thoracic ايش يسموها؟
upper thoracic.
upper thoracic or proximal thoracic curve, and then وإيش باقي؟
lumbar curve.
lumbar curve. وأوقات قليلة you might even go lower down to the lumbosacral. هذا new modification of the classification. لكن هذه main curves that you look at. So when you identify a curve like what you see in front of you, you need to measure the magnitude of the main curve. فأول challenge بالنسبة لك is to find the real curve where exactly it's stacked at. طبعا الكيرف اللي قدامنا هذا حيكون بدأ تقريبا من فين؟ احنا شايفينه من يمكن T5 about T5 إلى maybe L1 ولا T12. The magnitude هنا كم قسته عندك؟
around 33.
Around 33. طيب والبروكسيمال كيرف البروكسيمال كيرف
اقل هو
الثوراسيك كيرف حيكون من نفس البدايه حقتك في الكيرف المين الى T1 where the curve get back and then you measure it and you have to go down and measure من نهايه الكيرف حق المين ثوراسيك اللي هو T12 مثلا الى نهايه اللمبر. And by doing those, so you have 3 curves to be measured. وبعدها حنيجي نشوف لبقية الpoints. طبعا مع الأسف الإشاعة هذه is not a proper one. بإيش؟ It did not show a trunk كامل مع البلبس. ما احنا عارفين إذا في عندنا trunk shift واضح أو لا. Usually that is not a proper one. We ask the technician to open the window to show us the side of the ribs, نهاية الربس من الطرفين مع البلفس عشان نعرف الترنك هذا is shifted or not. And also لما نيجي نطالع للشولدر ليفل it's a bit difficult هنا لأنه ما طلع لغاية الكلافيكل برا بالكامل عشان نعرف الليفل of the height of the shoulder. طبعا احنا باين من عندنا من المنظر هذا انه عندنا الرايت shoulder is higher than the left. طيب now this is the initial analysis of this curve. What would you do in sort of as a sort of management في الحالة هذه؟
But we didn't look for the bending view to assess if it is flexible or rigid.
Okay. How does that help في الحالة هذه؟ She's a 33 and first presentation and she's 10 years old. What additional point we did not comment on in the X-ray? حاجة سألته عنها في الهيستوري وقلنا إنه she did not have any herb menarche yet.
The riser sign maybe we should look at.
طيب what do you think في الرايزر ساين في هذه البنت الآن في الإكس-راي؟
Sorry دكتور ما سمعتك.
الرايزر ساين.
Maybe 4 to 5.
طالعي كده closely في حاجة طبعا I can't blame you إنه الصور ما هي قدامك بالكامل بس لو طالعتي مظبوط ناحية الهيب I will give you a hint طالعي في الهيب جوينت كيف تشوفي فيه؟
The radiate is
open.
Yeah.
كلمة or riser it means what?
The risk of progression is high.
skeletal maturity.
Skeletal maturity is completed. هنا حيغير الكلام تماما. لما واحدة عمرها 10 سنوات وما بدأت الميناركي والترايديات فاتح زي كده so this is definitely a riser 0. صحيح الإشاعة ما هي واضحة عشان تحكم عليها لكن this is the points that you look at and then All these points بنحطها عشان it will help you in decision making. Clear?
Yes.
طيب نرجع للقرار. Anybody would like to help in decision making?
هاي شباب R3 أو R4.
R4.
في أنا وأحمد الرياعي.
يلا يا أحمد. لا
إحنا
أنت
اثنين أحمد.
غشاش، أنت شفت الحالة، أنت غشاش ما شفت.
أيوة we will do bending X-ray.
طيب.
Then we will Jacob angle how much this fracture more than 25 or no.
Good. طيب. Let's say you did the bending views and it's still above 25. يلا إيش حتسوي؟
Still above how much?
Above
This
25.
45.
خليني أقول لك نفسها زي ما هي الآن 30 زي ما قاسها أحمد. سويت البندنج ولقيتها almost 30 برضو.
30 ها؟
Yes.
Okay. Yeah. In this scenario, we will go for the bracing.
Okay. طيب إذا سويت البندنج ولقيتها أقل من 25. Let's say was 22. إيش حتسوي؟
Only physiotherapy, pain management, and observation.
Okay. So having the magnitude, it's already above 25 to 35 in this stage of maturity indicates a bracing. So bracing is needed regardless of the bending views. The bending views is mainly to hear about structural criteria, to know about what to do surgically. So in this age, it's not really important. By just looking at the X-ray that you have right now, you need to do something. The first thing you would think of هو bracing. Okay, so I agree with you. We did the bracing. Can you show us the next slide? This is the brace. طيب سوينا الطلب حقك يا طويل العمر وهذا البريس. What do you think? كيف حتحكم من البريس إنه effective and how would you follow your patient?
I will see the scoliosis if it's correctable or no. Flexible, and if the cube angle less than before. If it's less or same, we will do just observation and follow up and check if there is progression with the tie.
What will be your frequency for follow-up?
And this age group and the razor sign is 0, we will give appointment every 6 months, 3 to 6 months.
Okay. So you will bring her every 3 to 6 months?
Yes.
طيب. نزودها شهر كمان خليها 4 to 6 months. Every 4 to 6 months follow-up. What sort of scoliosis are you dealing with right now?
adolescent idiopathic scoliosis.
Okay. أحد عنده اعتراض؟ أنا عندي.
Yeah, because there is just a problem we don't know about this issue. But in this age group, most probably it's idiopathic, adolescent idiopathic scoliosis.
I agree with you. جزء من كلامك. لاحظوا يا جماعة أنا بقول 10 سنوات ولها سنتين عندها السكوليوسيس موجود. So would you still call it adolescent?
Juvenile دكتور. Juvenile.
It's a juvenile. مين قال juvenile?
انا عبد الله الصابر.
عبد الله، تفرق يا عبد الله؟ يعني ما هي ايديوباثيك في ايديوباثيك يعني.
والله هو الموضوع الايج يا دكتور، انه في الجوفينايل بيكون ميلي فروم 4 to 10.
4 to 10 ما سمعت.
يعني في الجوفينايل ايوه بيكون مينلي الجوفينايل بيكون مينلي 4 to 10 الايدج اوف برزنتيشن. فبقى ادلت لا بيكون افتر ذات يعني مينلي.
مظبوط، فانا agree with you. It is not adolescent لكن it is a juvenile. السؤال هو ايش الفرق في الكلمه اللي احنا بنقولها؟ ليش نقول هذا juvenile؟ ما ينفع نقول. انا اعترضت على كلمه احمد انه no it is not adolescent it's a juvenile. بس هي عشان العمر ولا لها معنى اخر؟ هذا السؤال. if you labeled someone juvenile هل هو نفسه like adolescent؟ هي دي النقطه.
In the management the same, but I think in the difference in the natural history of the disease.
يفرق معاه ايش الناتشرال هيستوري؟
They have
women.
a higher risk for progression in juvenile.
Okay, this is one. Additional. ايش اللي يفرق ثاني في الجوفينايل عن الادوليسنت؟
I
انه
think
can be fatal if not treated properly دكتور.
نعم.
can be fatal if not treated appropriately.
Can be fatal. It depends on the severity of the scoliosis. لكنها you can't call it fatal by just being juvenile.
and also this if younger age than 10 we will need MRI.
ليش؟
To rule out spinal cord pathology.
Exactly. These patients would have a higher chance of having intraspinal pathology. So by just saying juvenile, هنا as a spine surgeon who's planning to operate in these patients, they will open their eyes wide. لما تقول كلمة I'm referring to you a juvenile scoliosis rather than saying I'm referring to you adolescent scoliosis. But these two makes a big difference. Having a juvenile scoliosis is by itself an indication to do an MRI for a possibility of having intraspinal pathology. And if there is an intraspinal pathology, commonly it needs a specific different plan according to the pathology that is there. هذا اللي كانت فارق معانا في النقطة حقتنا في المانجمنت الآن. تفضل. في شيء؟ في صوت كذا طلع انا سامع لوحدي.
لا هذا شيء ممكن طيب. جوال سوى فايبريشن.
طيب جميل. عموما this is a juvenile scoliosis and according to the magnitude of the curve we've started bracing and then we were following this patient closely every 4 to 6 months time and then within about 6 months time we've noticed that her curve changed. As you see in this x-ray is becoming more and the ribs start, you could see it start to packed on one side compared to the initial one. And the following x-ray, can you go with the next one? This is the second one after 2 years that was on bracing. And this is the situation now, 2 years from the primary sitting. And from the primary presentation, this is the X-ray. يلا كمل second senior. أحمد.
احمد مين دكتور؟
مين معاك سينيور ثاني اسمه احمد؟
في احمد الرياعي.
رياض.
أي.
هو السينيور الثاني ولا في احد غيره؟
في غيره كثير.
ما
في
شاء الله.
R3 كلهم زي سينيور ما شاء الله.
طيب يلا يا رياض.
Yeah, we in this there is a progression of the cope ankle, and there is left thoracolumbar and compensated right lumbar curve. We will do bending X-ray again, okay, and we will prepare the patient for surgery.
You will prepare the patient for
surgery.
طيب ايش additional findings in this X-ray?
There is a progression of the curve. Now there is thoracolumbar scoliosis and left thoracolumbar scoliosis and right lumbar as well, and there is no kyphosis, only scoliosis. But the angle it's really high. It's, I think, more than 70-80 or more even.
طيب أعطيني full details الآن about the finding in this X-ray. How would you analyze to make a plan?
Okay, this is BE view of the skeletally immature patient, showing that there is left thoracic scoliosis. It looks structural, more than 60, and right lumbar compensated curve, and there is no kyphosis. And there is shoulder tilt as well. And there is rotation.
طيب سنبل كمل. ايش الاشياء الثانيه اللي المفروض you mention it?
It's deviated from the mid-sacral line, and also we need the flexion extension view to determine the structural and the structural curve and major curves in this patient. And there is also some sort of rotation. We can see the ribs on the left side is asymmetrical to the right side.
Good. About the shoulder?
There is some the height in the right side, as Ahmed mentioned, it's higher than the left side, and there is no pelvic tilt. Slightly high, very, يعني not very much.
طيب. Does that mean something to you?
The level we does not need to fix the upper level. I think C7 up to C7. I'm not sure up to which level. I think T1 or C7. As long as there is no shoulder tilt.
طيب عادي. يمكن السؤال ده مفروض انه يكون بعد ما تحدد لي الكيرفات. الان مثل ما ذكرت الدكتوره عندك 3 كيرفات: main thoracic, proximal thoracic and lumbar curve.
Lumbar, yes.
الماجنتيود عندك هنا كم؟
The higher in the thoracic curve, main thoracic curve.
So main thoracic انت قستها ما قستها هنا هنا من نظرة العين كذا I think it's حاجة تركزوا عليها يا شباب، يعني يمكن فيها شوية صعوبة إنكم تعرفوا الكاب أنجل بشكل كويس. بكل بساطة تيجي على الإند بليت اللي أنت شايفها أوضح حاجة the most tilted one، حتلاقي نفسك بين يمكن 2 vertebrae أو 3 vertebrae، فتشوف مين فيهم الموست tilted وتاخذها. فهنا لو طالعتوا في المين ثوراسيك upper segment مين الموست tilted vertebra؟ حتعدها بكل بساطة، يمكن من الصعوبة اللي عشان نسهلها تعد الربس، عد الربس حتعرف مين فيهم الموست tilted.
هذه مناسب بس يعني
موافقين على القياس اللي قاسه أحمد هنا؟ طبعا من طريقة سؤالي ماني موافق عليه أنا. مين موافق على هذه؟ أكيد إنها ما هي المطلوبة، لو طلعتوا في اللي تحتها حتلاقوها مايلة أكثر. بكل بساطة أنت لما ترسمها along the cortex of the end plate, the sclerotic white line of the end plate، حتلاقي إنه اللاين يكون أعلى لو مشيت معاه، فحتلاقيها السيجمنت اللي تحت حيعطيك أنجل أكثر، فبالتالي هذه هي البروبر 1. تمام؟ فبرسمتك هذه تكون حددت الكيرف اللي فوقه، والاند الثانيه اللي تحت حددت بيها بدايه الكيرف اللي تحت. حتى الليمب اللي تحت لو طالعته، انا برضو عندي اعتراض على رسمه احمد، لو طلعنا في الفرتبرا اللي فوقها
ايوه
تلاقي انه اللاين ماشي مور لو طلعت في اللي فوقها. مظبوط؟
يس.
فبالتالي تكون حددته. ما شاء الله تقدر تقيس.
ايوه لا بس ما حطلع زاوية، ما حطلع رقم، ممكن يجيب منقل بس
ما يقيس.
لا بس انه يرسم يعني
بس يرسم. مظبوط. فكده حتى اللي فوق لسه المفروض ترفعه زياده لو طالعت الان بليت كيف جايه، وعينك حتى على اللور ان بليت اوف ذا سيم فيرتبرا، بتلاقي نفسك شويه تطلع من الناحيه دي، شويه تطلع من الناحيه هذه حق الخط نفسه، بحيث انك تيجي exactly align with the vertebra itself in term of tilting، وبكده تعرف انه والله هذه هي البروبر 1. مظبوط كده حيكون البروبر 1. حددت المين اللي هو الموست اجريسيف كيرف، خلاص كده سهل عليك انك تشوف اللي فوق فين، تطلع للتي 1 تقيس مع اللاين هذا، وتنزل مع اللاين الاخير اوف ذا مين ثوراسيك، وتحط على ال 4 ال 3 حتلاقي اللاين جاي مظبوط معاهم، وكده طلع لك 3 كيرفز يعني. وهنا حيكون عندنا مهم، خلاص عرفنا ال 3 كيرفز، وبعدها نبغى نعرف الاستراكشرال كرايتيريا. نرجع للسؤال حق الشولدر. if I tell you the proximal، ركزوا معايا في هذه يمكن فيها شوية صعوبة، بس أبغاكم تلقطوها لأنها مهمة جدا في الاناليسيز والديسيجن ميكينج. طبعا كلنا متفقين على إنه نبغى نسوي الستراكشرال كرايتيريا، والستراكشرال كرايتيريا بتعتمد على حسب صلابة الكيرف. if I tell you the main thoracic is structural، ما هو مفاجئ لكم. اللمبر كيرف is also structural في البندing criteria. أما الأبر thoracic was equivocal. عملنا اللاين and it was about 25 or even 24 degree of a proximal thoracic curve اللي هو بدأ من upper thoracic إلى T5 اللي هي ما حين رسمينها إحنا عليها اللاين أبقى T5. إيش عندنا في الصورة هذه يدعم الكرايتيريا of the upper thoracic is structural؟ لأنه لو قلنا إنه ما هو structural by default إيش حنسوي فيه؟
we'll leave it.
هنسيبه
أيوه.
ببساطة، ما هو شغلنا نسيبه، وبالتالي هنسوي. تفضل.
One shoulder higher than the other shoulder, so that there is that means that there is rotation, and we need to fix more proximal.
جميل. الآن إحنا عشان نمشي على هذا البلان إنه البروكسيمال thoracic is non-structural والstructural فقط هو المين thoracic، فباي ديفولت حنبدأ الانسترومنتيشن من الليفل حق T5 maybe T4 إلى اللور segments. فين حيكون؟ about L3. طبعا الكلام ده حنحكمه بعد ما نشوف البندنج views. Next. Point اللي I want you to clarify to you here is the shoulder. نظرتكم في الشولدر ما كانت مريحة لأنه تقريبا متشابهين. متى يكون مريح وضع الشولدر لنا حتى نمشي على هذا البلان؟
على حسب اتجاه أي أعلى من الثاني.
تمام. ليش الأشعة هذه ما هي مريحة إن نمشي بهذا الكلام؟
في روتيشن دكتور.
الشولدر الرايت side is not really high as supposed to be. We are expecting a thoracic curve الموجود بالماجنتيود حقه هذا، لو أخذنا الرقم حيكون definitely في التسعينات ولا أكثر.
أي.
إنما طالعوا في وضع الشولدر كيف؟ تقريبا متساويين. توقعنا إيش يكون في الماجنتيود هذا؟
المفروض يكون أعلى. الرايت.
عالي بشكل واضح. مظبوط؟ متفقين معايا يا شباب؟
يس تمام.
فبيكون الشولدر في الليفت طايح نتيجة الكونكيف سايد هو الليفت. لو مشينا على هذا البلان ورجينا وسوينا T4 لغاية تحت وعملنا كوركشن للكيرف، ايش حيحصل في الشولدر يا شباب؟
الرايت حينزل حيطيح.
الرايت حينزل. المشكلة مو في الرايت،
في الليفت.
المشكلة حتصير فين؟
في الليفت حيطلع فوق.
بالضبط. حيطلع الليفت high way more than you expect, and that means the proximal curve is a structural but you didn't pick it up. Simply going back to this X-ray, it will show you that proximal curve is structural and you cannot ignore it. وضحت الصورة؟
يعني كل دكتور يعتمد على موضوع الشولدر عندنا في الموضوع.
بالضبط. البروكسيمال كيرف مرتبط ارتباط قوي بالشولدرز. You miss it, you misinterpret it, it will give you an issue with the shoulder. حالة زي هذه واضح إنه البروكسيمال كيرف has to be involved. Otherwise, you will see a very high left thoracic curve post correction. لأنه بكل بساطة أنت جيت شايف الكونكافيتي اللي تحت هذه فردتها، فمع فردتها يروح يطلع الليفت كيرف هاي، ليفت شولدر هاي، وباي ديفولت لأنه الكولم هنا حيطول. مظبوط؟ فأول ما تطول الكولم في الناحية هذه هيرفع لك الشولدر higher, and then you will have a mismatch shoulder and patient won't be happy. وضحت؟
Yes.
additional point في الإكس راي هذه نرجع للستوري حقتنا اللي تكلمنا فيها، هو وضع اللنج. Can you see what's happened to the lung on this side?
In the left side there is it's shrink or collapse.
Yes, absolutely. So this patient now is a fully diagnosed case of a bronchiectasis with a repeated chest infection, end up with a bronchiectasis plus the scoliosis. So what sort of lung disease you're handling right now with these two diagnoses, scoliosis and bronchiectasis?
Constrictive and
thoracic
restrictive.
insufficiency syndrome دكتور.
Sorry?
أو thoracic insufficiency syndrome.
No, that's different.
Restrictive.
So it is, when we say scoliosis and the volume of the chest is affected, here we're talking about restrictive lung disease. So that's that's affected by scoliosis because of the volume is reduced due to the curve. Now we have additional pathology, which is a bronchiectasis. So that is going to give you the second lung disease, which is an obstructive lung disease. So you have two issues affecting that lung. So that is going to be a challenging condition you need to make a plan for if you want to intervene. So let me see the bending. عندك البندنج طلعت؟ هذه البندنج. يلا مين الأذر سينيور موجود يعطينا بلان للحالة للفاينل سيت اب للحالة دي. تعرفهم يا احمد؟ قول لي مين باقي سينيور مفروض نساله ما سالناه من السينيور موجودين.
صواف موجود.
يلا يا صواف.
Okay, this is X-ray of the long film of the whole spine for skeletally mature patient, showing that bending views, and I can see that there is an obvious scoliosis in the upper thoracic and main thoracic and then the lumbar area, not corrected with the bending.
طيب give me the final plan. خلاص كلام ده خلصنا منه، بس اعطيني الفاينل بلان تبعك.
Okay, for this patient, we will go for anterior and posterior spinal fusion and instrumentation.
Okay.
From the upper thoracic up to the L3.
From upper thoracic فين؟ اعطيني levels. Which vertebra?
From T1, T2, sorry, T2 to L3.
Okay, T2 to L3. وانتيريور ايش حتسوي؟ Which way you will start? Anterior, posterior, one setting, two setting.
In a one sitting, sure. We can go for that.
So you want to go thoracotomy, and then what's your indication for thoracotomy?
I'm afraid that if I only fix it posteriorly, that I might end up with a crankshaft phenomena for this type of patient, as she's still.
She's 12 now. She's 12 now, and she has her menarche. And looking at the riser signs, if you look at the triradiate cartilage is closed, and the riser sign is about 3 in this stage. So you want to go from the front in order to prevent any possible progression like a crankshaft phenomena. That's one point you might think of it, لكن ما هو في الage هذا. Yeah, I will still consider that. What additional indication that made you say you want to go front? Agree with you. You need to add more.
حيكون عندي الكوركشن better for the whole spine, and I will save that will save for me the lumbar fusion levels.
يا صواف، يعني انت لما تفتح من قدام حتوصل لفين؟ حتوصل لغايه اللمبر؟ يعني انت ناوي تفتح فين بالضبط؟ ثراكوتومي ولا ثراكو لمبر؟ ولمبر
ثراكوتومي.
انت هتفتح ثراكو لمبر؟
ثراكوتومي.
ثراكوتومي فين؟ ايش الليفلز حقتك هتشتغل عليها؟ انت تتكلم دائما بناء على البلان حقك. انت هتفتح ثراكوتومي على فين بالضبط؟ على المين ثوراسيك اللي هو عندك واضح انه هو المين بوينتس في الكيرف تبعك هي الابيكس of the main thoracic. Then you'll be talking about T7, 8, 9 possibly 10. هذه هي الفرتبري اللي في الابيكس of the curve. So انت هتفتح ثراكوتومي في المكان هذا، والايديا حقتك الانديكيشن اول شيء I would say due to the high magnitude curve above 90 and bending criteria is less than a 50% of correction. This is an indication to go from the front. هذا clear justification to say I want to do an anterior release in order to control this curve.
Okay.
Clear? Additional point لو في السن الصغير you want to prevent crankshafting. Yes. When you go with the answer اللي قلتها من شوية you will preserve a fusion segment lumbar spine. هذا موضوع ثاني. لما يكون عندك curve you're talking about a curve in the lumbar spine. بس احنا ما احنا فاتحين lumbar. الحين بيقول ثراكوتومي. وضحت؟
يس.
وضحت؟
ايوه دكتور.
تمام. ف who agree to go 2 stages? I mean front thoracotomy and then going back. ما حد رد معناته ما حد موافق.
We can start to posterior if it's enough correction or acceptable correction. Then no need to do the thoracotomy.
هل هذا الكلام معقول؟ صعب. ما تقدر. خلاص انت فتحت posterior ما حتقدر انك انت تقول له والله حفتح قدام عشان اصلح الثاني. خلاص انت دان ديل الا اذا ما عملت الفاينل كوركشن. عملت الكوركشن لقيته مو ظابط فكيت الراد تسيبه مفتوح وتقلب البيشنت تسوي anterior release بعدين ترجع تقلب مره ثانيه and do the back. لكن خلاص انت ساعه ما فتحت posterior وحطيت التثبيت you cannot do anything من قدام. اي شيء حتسويه من قدام يبقى useless without going back and then operate in the back again. مظبوط؟
Okay. So if يعني لأنه هذه النقطة مش واضحة بالنسبة لي. يعني if we fix from anterior we can go posterior after that, but العكس لا.
في السكوليوسيس.
في scoliosis.
When you go from the front you have 2 goal. You have to justify clearly and make it in your plan. Are you going from the front to achieve a release only to get more mobility in that curve so you can address things from the back in a better way? أو إنك you're going from the front, doing a release and doing the fixation from the front and finish things from the front. يعني كله من قدام. You can do anterior instrumentation مع الريليز and correcting الكيرف فقط. هذا الكلام في حالة شبه دي إذا كان عندك only thoracic curve فقط. Only a thoracic curve. You could go with that option. في الحالة حقتنا هذه كونها high magnitude curve, you want to unstructure and very stiff curve. In order to address it, you want to add anterior for those kind of goals. But if you want to do that, you should a logic إنك أنت you do it from the front, finish it, and then you flip a patient, then you address things through the back or release تعمل كده.
اوكي
وضحت؟
تمام.
ايوه دكتور.
الآن عندنا مشكلة بقيت هي ايش؟
شولدر؟
لا الحين خلاص اتفقنا على الليفل. I agree مع الصواب. You have to go upper thoracic curve involved and you take it all the way لغاية اللمبر L3. عندنا مشكلة في البلان حقك هذا to go from the front and back. ايش اللي يخلينا ما نقدر نسوي الكلام هذا؟
Her lung condition.
Her lung condition. Her lung condition. So let's complete images. احنا قلنا عشانها juvenile you need to get an MRI. Look at the MRI. Any finding in the MRI?
No intraspinal anomalies.
No intraspinal anomalies. تمام. اللنج CT بين أي حاجة? That's also
no, I didn't
done to check if there is any abnormality in the lung, and obviously there was. Obviously you cannot see a lung in one side. مع السكولر في الكت اللي شايفينه axial. It was taken at a higher level, so going down mid level you could still see. شوف اللung كيف contracted on the left side. It was fibrotic with all of this due to the bronchiectasis. Due to that, anything additional to do before you take the patient to surgery? We electively admitted this patient, and we got the patient to be prepared for this procedure. What sort of service you will be using to help optimize this patient for the surgical intervention?
Pulmonology, anesthesia, intensive care, and infectious disease because she had bronchiectasis.
Very good. And occupational therapy. And this specific patient, we did admit this patient 5 days before the surgical procedure. We did the optimization of the patient condition, including ambo bagging to help the inflation of the lung. The anesthesia were really so much on their toes for putting this patient asleep. What would happen if this patient did not tolerate the procedure with the intubation part? At the time of, when you put this patient under GA for a long procedure with a patient who has a bad lung condition, يعني الانستيزيا ايش عنده مشكله؟ جالس يطفشك حق الانستيزيا رافض ينوم لك الحاله، يقول لك لا والله انا I cannot put this patient asleep. ايش عندهم مشكله؟ ليه رافض؟
restrictive lung disease.
طيب
عشان
هو كده
mechanical
حينومها وصحيها. خايف من ايه هو؟
mechanical ventilation or hyperoxygenation.
aspiration.
والنهايه تكون ايش؟ failure to extubate the patient. They will be ventilator dependent. هذه هي المشكلة الأساسية في الحالات اللي مثل هذه. When you try to optimize your patient in order to be prepared for this procedure, main points of failure to reach to the ability of extubating these patients. So, what is the additional point that you need to do before you in the planning في الحالات اللي مثل هذه؟
Neuro monitoring, sir.
Neuro monitoring غيرهم. How would you study the lung?
The pulmonary function test.
Pulmonary function test. It's very important to do that to know her status, and then with the help of the pulmonologist, you need to optimize this patient قبل التنويم وبعد التنويم in order to reach to a reasonable level, and you repeat the pulmonary function test to see the outcome of your intervention with the preparation, and if it showed a significant improvement, then you can proceed with the intervention. So due to all of these conditions, we elected to go only from the back, and we did what you've discussed for. You can show the x-ray now. You did already show part of it. So we went all the way up till the L3, I think, and we got a reasonable correction. And that was in 2014. What is the anticipated complication in these cases? Acute and late.
The superior mesenteric artery syndrome.
What is this syndrome?
Due to the hypercorrection, especially in the thin people, the liver will compress over the superior mesenteric artery, causing temporary temporary ischemia to the bowel, and it would cause obstruction and less movement in the bowel.
How would they present if they develop this complication?
Yeah, signs of obstruction like vomiting, abdominal pain, distension, and constipation with obstipation.
Weight loss والكترولايت imbalance كلها تيجي معهم.
Weight loss هذا كلام يمكن بدري، هذا يبغى له وقت. ها weight loss ما يجي الكلام. البرزنتيشن هذا بيكون متى على فكرة؟
هذا في الاي سي يو في اول يومين ثلاثه، وهي لسه
زالت في المستشفى، يعني اكيوتلي في اول يومين بعد العمليه. طيب and how would you manage them?
Supportive management. I'm keeping MPO, the patient MPO, and put nasogastric tube. Supportive management until it resolves.
Very good. So that kind of management has to be done. MPO, you manage the patient's fluid and manage the patient's symptoms, and it will improve by itself without any intervention. Okay, other complication?
Flat back syndrome. Infection, of course, neurological injury. As you said early, we can see that this patient might have neurological injury or infection. As a late, this patient can go to a flat back syndrome or hardware failure from the rod breakage from the pseudoarthrosis.
Or penetration of the canal. We need to examine her neurological status also.
جميل. Late complication?
Pseudoarthrosis, infection, and cutouts of the screws and crankshaft phenomenon.
Cranking is unusual since you get all of those levels. With the pedicle screws and instrumentation, even if you do it in a younger age, this is very powerful instrumentation. So أغلب الcrankshaft phenomena اللي بتسمع عنها وبتقروا عنها, it was made at what time? At the era of the hooks. اللي هي كان يعملوا instrumentation بالhooks. فالhooks hold only posterior elements. It doesn't hold pedicles. فالcrank shafting كانت تحصل في الفترات هذه بشكل أكثر لأنه anterior column is not under fixation. So in order to really to get the crank shafting في حالات pedicle screws بالذات الdense instrumentation بالشكل هذا is to have a failure of instrumentation. يعني ينكسر الراد أول شيء. لازم الراد تنكسر, السكروز تنكسر in order to let go get loosened. فبالذات في الايج اللي احنا بنتكلم عنه هذا she's 12 years and higher, then it will not be really clear. ورينا الصورة الأخيرة حقت last follow up. So this is in 2016.
Yes.
This is her last follow up. And obviously, she became a lady now. You can see even her body became bigger, and her shoulder level is good compared to what we had initially. And the planning was made, I think, adequately in this specific case in order to get a shoulder level that is almost equal compared to the initial condition. طبعا complication that you've elicits also should include a PGK. She can have a PGK at the higher level, and that's why we stop at T2. We don't stop at T1. And the lumbar spine also, we've stopped at the L3. She could have also a PGK at that level, lower than that.
معلش دكتور بس إيش ال PGK؟
Proximal junctional kyphosis or disease. Proximal junctional disease. This is also, whenever we instrument the spine anywhere, is our nightmare as a surgeon who operates in this part of the body as a spine, is because we stop at one segment and then we start to worry about the adjacent level, whether it's going to be collapsing or not. اللينك اللي ارسلته لك حق السيرفايكل, we also I've talked about that proximal PGK at the cervical spine. You can also send it للشباب يشوفوا التوبيك. كان برضو من الحالات الانترستينج, is a bit complex لكنها من ال possible cases to be encountered in case of cervical spine revision. طيب احنا كده we finish this case. We'll leave questions لكم إذا في أي حاجة تبغون نجاوبها.
شباب
يعطيك العافية دكتور, الله يسعدك.
واضحة الأمور كلها؟
إيه ما شاء الله تبارك الله.
طيب باقي شيء أحمد؟
الله يعطيكم العافية دكتور.
الله يعافيكم.
إن شاء الله نرجع تاني بعد العيد بإذن الله.
إن شاء الله وأنتم طيبين. يلا بالتوفيق إن شاء الله.
الله يعطيك
وإن شاء الله بعد العيد يكون لقاء آخر, وكل عام وأنتم بخير.
شكرا.
سلام.
وأنتم بخير.
وأنتم طيبين. مع السلامة.